Subarachnoid hemorrhage is one of the most time-critical neurological emergencies, where early recognition and targeted intervention can change the patient's trajectory. In this lecture, we'll unpack the essential concepts, from the underlying mechanisms to the clinical decisions that guide timely and effective care. Welcome to the StudyNeuro lecture series, where complex neuro topics are presented with clarity and clinical relevance. In this session, we'll develop a structured understanding of subarachnoid hemorrhage. We'll start with what it is, why it happens, and how it typically presents. Then we'll move into the diagnostic approach, including the imaging and grading systems that guide management. From there, we'll cover acute stabilization, definitive treatment options, and strategies to prevent complications. Finally, we'll review the key factors influencing prognosis and what effective follow-up care looks like. Subarachnoid hemorrhage is a critical emergency where blood collects between the pia and arachnoid mater. Trauma is the most common cause, while spontaneous cases usually result from aneurysm rupture. Quick recognition and immediate management are essential to reduce complications and improve survival. Subarachnoid hemorrhage represents a small but significant fraction of strokes. Aneurysmal cases most often occur in adults in their mid-50s to 60s, with women affected more frequently than men. Without prompt treatment, mortality remains high, approaching half of patients. Subarachnoid hemorrhage can arise from trauma, typically involving bleeding from cortical or basal cistern vessels, or it can occur spontaneously. The majority of spontaneous cases are due to ruptured intracranial aneurysms, but other vascular abnormalities, such as cerebral or spinal AVMs, arterial dissections, or small superficial artery ruptures, also contribute. Less common causes include inflammatory or vasculopathic disorders, coagulation abnormalities, dural sinus thrombosis, tumor hemorrhage, and certain drugs or systemic diseases. In some patients, no clear cause is identified, highlighting the diverse etiology of this condition. Patients with a subarachnoid hemorrhage typically present with a sudden, severe headache, often described as the worst headache of their life. It can occur at rest or during exertion, and in some cases, there may be a preceding warning headache days or weeks before. Other common symptoms include nausea, vomiting, light sensitivity, and neck stiffness. Roughly 40% of patients may experience a brief loss of consciousness, and if the aneurysm presses on nearby brain structures, focal neurological deficits can also be seen. In patients with subarachnoid hemorrhage, altered consciousness is common and can result from raised intracranial pressure, brain tissue injury, hydrocephalus, or reduced cerebral blood flow. Hypertension and focal neurological deficits, such as oculomotor palsy or hemiparesis, may also be observed. Ocular hemorrhages occur in 20 to 40% of cases, affecting the subhyaloid space, retina, or vitreous, a condition known as Terson syndrome, often associated with elevated intracranial pressure or rebleeding. Most of these hemorrhages resolve spontaneously over several months, but persistent visual impairment may require surgical intervention, such as vitrectomy. Meningeal irritation is frequently present, manifested as neck stiffness and sometimes positive Kernig or Brudinsky signs. Subarachnoid hemorrhage carries several early complications that can be life-threatening. Rebleeding is most likely within the first 24 hours and, if untreated, has a mortality rate of around 70%. Hydrocephalus can develop either acutely or over time, and seizures are also common. Raised intracranial pressure may lead to herniation if not managed promptly. Additionally, many patients experience associated intracranial hemorrhages. These can include intracerebral hemorrhage in up to 40% of cases, intraventricular hemorrhage in about a quarter, and subdural hematomas in a smaller proportion. The location of subdural blood often points to the source. Convexity hematomas usually arise from posterior communicating artery aneurysms, while interhemispheric hematomas are more often linked to distal anterior cerebral artery aneurysms. Beyond the acute phase, subarachnoid hemorrhage carries several delayed risks. Neurologically, the major threats are vasospasm, leading to delayed cerebral ischemia, chronic hydrocephalus, late seizures, and longer-term cognitive or mood changes. Rebleeding can still occur if the aneurysm remains unsecured. Systemic complications are also common. These include stress-related cardiac dysfunction, neurogenic pulmonary edema, thromboembolic events such as DVT and PE, and electrolyte disturbances, especially hyponatremia from SIADH or cerebral salt wasting. Patients with ventricular drains or prolonged ICU stays may also develop infections like ventriculitis or pneumonia. When evaluating sudden, severe headache, always rule out subarachnoid hemorrhage first, especially when patients report a sudden, worst ever episode. Prompt CT and, if needed, LP are essential. If imaging is clear, consider benign thunderclap headache, which can recur without evidence of bleeding. Also watch for reversible cerebral vasoconstriction syndrome, marked by angiographic beating and possible transient deficits, often triggered by vasoactive drugs or the postpartum state. Some causes are benign and situational: sharp orbital frontal pain during flights or explosive headaches at orgasm in patients with normal neurologic exams. The key is rapidly identifying true vascular emergencies while recognizing patterns of benign thunderclap presentations. The first-line investigation for suspected subarachnoid hemorrhage is a non-contrast CT scan, which is highly sensitive within the first 6 hours. Look for high-density blood in the subarachnoid spaces, commonly in the occipital horns, sylvian fissures, and basal cisterns. Hydrocephalus can be seen in about 1/5 of aneurysmal cases. The pattern of bleeding can suggest aneurysm location. Blood along the anterior interhemispheric fissure often points to an AGCOM aneurysm, while unilateral sylvian fissure involvement suggests an MCA or PCOM aneurysm. This helps guide further vascular imaging and management. If CT is negative but suspicion for a subarachnoid hemorrhage remains, lumbar puncture is nearly 100% sensitive. Look for persistent blood, elevated opening pressure, and xanthochromia, which appears within hours and is usually present by 12 hours. Collect minimal CSF to reduce rebleeding risk. FLAIR MRI is excellent for detecting subacute or remote hemorrhage, but is unreliable in the first 24-48 hours. CT angiography provides detailed three-dimensional images of cerebral vessels, helping to distinguish aneurysms from surrounding structures and guiding surgical planning. It's also useful for detecting vasospasm after a subarachnoid hemorrhage. Magnetic resonance angiography is less sensitive for small aneurysms and can be affected by flow dynamics or aneurysm calcification. Its main role is as a non-invasive screening tool in high-risk patients, such as those with multiple affected first-degree relatives. Digital subtraction angiography is the gold standard for detecting cerebral aneurysms and vasospasm, identifying the source in most subarachnoid hemorrhage cases. A complete study images the most suspicious vessel first, includes all 4 major cerebral arteries, and adds targeted views if an aneurysm is found. Before labeling an angiogram negative, flow across key vessels and smaller arteries like the picas must be verified to avoid missing subtle lesions. For patients with suspected subarachnoid hemorrhage, a focused set of laboratory tests guides early management. An arterial blood gas helps assess oxygenation and ventilation. Electrolytes, urea, and creatinine reveal metabolic or kidney disturbances. A full blood count and coagulation studies identify risks related to anemia, infection, or impaired clotting. Checking serum glucose is important, since abnormal levels can worsen neurological injury. Measuring serum and urine osmolality helps distinguish syndrome of inappropriate antidiuretic hormone secretion from cerebral salt wasting when sodium imbalance is suspected. A chest X-ray is also useful for detecting aspiration or pulmonary complications. Grading scales in subarachnoid hemorrhage guide prognosis, treatment, and communication. Clinically, the Hunt-Hess scale ranges from grade 1 with minimal symptoms to grade 5, reflecting deep coma and severe deficits, with survival decreasing from around 70% to 10%. The World Federation of Neurosurgical Societies, or WFNS scale, parallels this by combining the Glasgow Coma Score with motor deficits for precise severity stratification. Radiographically, the Fisher scale assesses the volume and distribution of subarachnoid blood to estimate vasospasm risk, ranging from thin focal hemorrhage to thick SAH with intraventricular blood. The modified Fisher scale further refines this risk, showing higher vasospasm rates when intraventricular hemorrhage is present. Together, these scales provide a structured approach to patient assessment and management. Early management focuses on rapid stabilization. Secure the airway in any patient with reduced consciousness or poor protective reflexes. Ensure adequate oxygenation and maintain normal ventilation. For circulation, establish intravenous access. Keep the patient appropriately hydrated with isotonic fluids, avoid hypotonic solutions, and correct electrolyte abnormalities while closely monitoring fluid balance. After stabilization, focus on controlling blood pressure and intracranial pressure to prevent rebleeding and protect the brain. Elevate the head of the bed, minimize stimulation, and treat hydrocephalus promptly. In the intensive care unit, maintain continuous neurological and cardiac monitoring, manage pain and sedation, provide antiemetics and stool care, prevent deep vein thrombosis, and keep body temperature within normal limits. Nimidipine should be started immediately to reduce the risk of delayed cerebral ischemia. Anti-seizure medications are used selectively, typically levetiracetam or phenytoin. Early treatment of the aneurysm, either by endovascular coiling or surgical clipping, is essential to prevent rebleeding and improve outcomes. Acute complications require prompt management. Hydrocephalus may need urgent drainage or a shunt. Rebleeding is prevented through early aneurysm treatment and blood pressure control. Sodium imbalances should be corrected carefully to avoid further brain injury. Seizures, including non-convulsive forms, must be monitored and treated with anti-seizure medications when present. Vasospasm and delayed cerebral ischemia typically occur between days 3 and 12 after subarachnoid hemorrhage. Prevention includes nimidipine and maintaining normal fluid balance. Treatment involves careful blood pressure support, adequate oxygenation, and, if needed, endovascular procedures such as balloon angioplasty or intraarterial vasodilators. After subarachnoid hemorrhage, sympathetic surges can affect the heart and lungs. Neurogenic stress cardiomyopathy may temporarily impair heart function, managed with supportive care and inotropes. Neurogenic pulmonary edema results from fluid shifts to the lungs and is treated with supportive ventilation, intracranial pressure control, and medications when needed. Outcomes after subarachnoid hemorrhage depend on early stabilization, preventing rebleeding, and managing vasospasm. Severity at presentation, age, and WFNS grade predict recovery. Around a third of survivors have significant disability, and mortality is highest before hospital arrival and in the first month, mainly from complications, rebleeding, and vasospasm. Post-subarachnoid hemorrhage care involves scheduled imaging to detect residual or recurrent aneurysms and monitoring for hydrocephalus or shunt issues. Rehabilitation targets motor, speech, and cognitive recovery, while mental health screening addresses depression and fatigue. Ongoing assessment of functional status guides return to work and overall recovery. In summary, early recognition of subarachnoid hemorrhage is crucial for patient outcomes. Prompt imaging and intervention reduce complications, while grading scales help guide treatment decisions. Combining imaging modalities ensures accurate aneurysm detection, and coordinated multidisciplinary care supports optimal recovery. Thanks for watching. Don't forget to like, share, and subscribe to StudyNeuro for more clear, high-yield neuro content every week.